for last week, we had a problem with the internet. So you can see on the screen, we've got the agenda. I just want to mention that Dr. Gibson will be replaced by Dr. Portia from Zimbabwe presenting. In the housekeeping, we just want to ask you to all please keep your cameras off and you're muted. There will be a question and answer box, so you can just type your questions in there. We will present the QR code just now again, that you can just scan. It is also on the Telegram. And if you do have a problem, you can just send us a note and we can see how we can help you out. And then we will start with the session, and afterwards we will have questions and answers. So if you have any burning questions, you can just type it in the question and answer box and we will address that. Thank you. I want to now just share my screen and just share the QR code again just for a few minutes. And we'll see here it says the time is today the 12th, and you can start scanning this code. And at the end of the session, we will display the end code that you also need to scan. I'll just give you all a minute or two to just scan that. Okay, everybody, I'm going to stop sharing my screen and I'm going to hand over to Dr. Edua, and he's going to give us an update on the status of COVID in Africa. Thank you. Dr. Edua, over.
Thank you very much. Good morning, good afternoon, good day, everyone. Can you all hear me? Please, Hannah, can you confirm?
Yes, we can hear you very nicely and I can see your screen. Thank you.
Thank you very much. You are welcome to Series 3 of our Infection Prevention and Control webinar. Today being the first session. So my presentation is on the epidemiological update as of today and a summary report of our Series 2 IPC webinar. So, looking at the global epidemiological situation of COVID-19 as of 9 a.m. East African time today, on the left-hand side shows the map of the world, and the dark blue color representing the countries reporting more than 100,000 cases, and the very light blue color shows the country reporting between 1 and 1,000 cases globally. The epic curve shows the global number of COVID-19 cases by day across the region. And the Pan-American Health Organization region, represented with blue color, is reporting highest number of cases globally. Overall, we have about 200 million cases, confirmed cases, resulting in more than 730,000 deaths, putting the case fatality rate to be 3.7%. This slide shows the trend of COVID-19 cases in Africa of 9 a.m. East African time today. And on the left, you see we have two EpiCov. The one on the top shows the cases, number of new COVID-19 cases by day on the y-axis across the 55 member states in Africa. And as you can see, the percentage increase in the past 1 week is 8%. But looking at the EpiCov below, the average percentage increase is 9% when we remove South Africa. And as you are aware, South Africa is reporting more than half of the total cases being reported across Africa. And in the past 1 week that we are looking at, the East Africa region reporting the highest percentage increase of 13%, and Central Africa region reporting the lowest, being 1% in the last 1 week. Overall, we have more than 1 million cases across the continent, which has resulted to more than 23,000 deaths with case fatality rate of 2.2%. The good news is we have more than 70% that have recovered. This slide shows the table with the distribution of new cases and recoveries by region as at 9 a.m. East African time today. And the Southern Africa region reporting the highest with 3,049 cases between yesterday and today, and the Central African region reporting 4 cases. Overall, we have the 7,012 total cases and the death to be 255. This is a slide that shows the map of African member states reporting COVID-19 cases. And as you can see, we have 35 countries reporting less than 5,000 cases, 7 countries reporting between 5,000 and 10,000 cases, and 1 country reporting more than 100,000 cases. This slide shows the trend of COVID-19 being done across the continent. And as of today, we've done more than 9 million tests with test case ratio to be 9 and positivity rate of 11%. In the next 4 slides, I'll be taking us through the summary reports of our Series 2 IPC webinar. And overall, we have 3,735 attendees across the 6 webinars that we have during the Series 2, with 3,042 participants in the English webinar and 693 participants attended the French webinar. And on the right side, we'll see the number of participants per webinar. For the English, we'll see that we have the highest to be 558, at the 6th webinar, and the lowest to be 422 during the week 1. For the French, the highest was also at week 6, which happened to be 138, and the lowest at week 4, which happened to be 50 participants. And the number of panelists that we have for English to be 21 and French 18. These are the countries, the top countries represented during our webinars, with Nigeria having the highest number of participants, and followed by Kenya, South Africa, Zambia, Ethiopia, Ghana, Zimbabwe, and Uganda. Across the 55 African Union countries, we have 46 countries attended, with 33 non-African Union countries represented during the English webinars. For the French, we have 39 African Union countries with 12 non-African Union countries represented during the French webinar. And the highest happened to be from DRC. This slide shows the community of practice on our Telegram group, where the engagement continues after the webinar that we normally have on Wednesdays and Fridays. And this gives the participants and the community of practice opportunity to continue the discussion and ask questions. So for the English group, we have 686 and French to be 208. As you can see that this number cannot be compared. This is less than 1/3 of the total number of attendees that we have for the series 2. So I will encourage all our attendees to join our community of practice, and the link will be put in the chat function so that you can join our community of practice. Thank you.
Thank you very much, Edouard. It's very interesting to see. I think it's great that we can see how many people that participate. And we want to ask people to please advertise this widely. It will happen every week at the same time here, on a Wednesday the English, and then on a Friday the French side. I want to take this opportunity now to introduce Professor Cheyenne Mehtar, previous ICANN chair and also the founder of ICANN, and she's going to present to us on ventilation. Prof, over to you.
Thank you very much. I can't seem to start my screen. I think it's because it's already occupied.
Well, can you just stop your screen?
Thank you very much. Thanks a lot. Let's see where we are with this thing. Oh. I think rather, I apologize. I will just, I thought I'd opened it, but I obviously hadn't. So let's try again. Okay. It doesn't help when you're too prepared, you know. Things go wrong like they do now. I can't seem to get back onto my system. Okay, can you see my
I can see. Let's just start at
slide. I'm going to do it now. Okay, thank you very much. Thank you very much, and I apologize for that. It's a great privilege again to be on this course. It's a very exciting course, and it's the good thing about it is it's very geared towards working in Africa. And hopefully today I will address something that has been a great, it's been a great problem across the globe, but hopefully I will be able to give you some ideas of how we can improve that for us. And so on that note, if I could just start. Everybody's really concerned about, obviously, about COVID-19. I mean, there's a big thing about it. But we seem to always be dashing towards the personal protective equipment rather than looking at the holistic picture. So in the holistic picture, we obviously need to have administrative controls in place like triaging of persons, the engineering controls, which include ventilation and obviously the oxygen requirements and so on. And then, of course, PPE comes right at the end. So what I want to, if I hope by the end of this talk, I would like to explain how ventilation is absolutely vital. So when is it important for IPC? Which areas require increased ventilation? Can face covers and PPE be a substitute for ventilation? I think you know the answer to that already, but we'll go through it. And what can we do to improve ventilation? So just to remind you, this is the community that we talk about. And between the community and the person that gets either asymptomatically or symptomatically infected, we are advocating cloth face covers. When this person comes into another environment, that person can then, is infectious, as you know, in the pre-symptomatic and the asymptomatic phase, and is infectious only for the first couple of days once the symptoms develop. However, it can be up to about 7 to 8 days. So in this given environment, two things happen. When they cough, their larger droplets, as you well know, goes into covering surfaces and contamination. And if there's not very good environmental cleaning, then they can be transferred from that to the hands, and from the hands it goes to the face. So that is very much contact. And this is why hand hygiene is so important, environmental cleaning is. Then, given the situation, you might have a very large number of droplets, particularly if you're very close to a patient and carrying out aerosol generating procedures. You get droplets which then become aerosolized and become very fine, and these move along, and this is the one that we help with social distancing. However, in the context of what we talk about for COVID-19 or for SARS-CoV-2, we know that there are only 3 organisms that actually are considered purely airborne, true airborne. One is tuberculosis, the other 2 are, of course, measles and chickenpox. So the opportunistic airborne are the ones that will actually carry on, maybe even up to 6 meters or so, in the absence of something that is absolutely vital, which is ventilation. So the basis of this group here, which I'm going to talk about, where you've got face covers and then there's escape, there's droplet that also helped by ventilation, and of course the airborne opportunistic transmission. So looking at the transmission via aerosols, there is something that is quite important to understand, and this is the fact that, this is the fact that the very small droplets which are produced during speech or cough will contain viral particles, which will remain viable, apparently, based on the evidence, up to three hours. Droplets will be transmitted either directly or indirectly. But what the most important thing is that there is a dose-response relationship of COVID, of SARS-CoV-2. The way it's transmitted is not entirely clear, but there is more and more evidence coming across that there is an element of aerosol transmission with this virus. And there are some examples which are becoming quite evident, particularly where there's closed systems and where ventilation is recycled, such as ships and so on. This is the one that you probably have all seen, and this is where the primary case occurred in the United States, where there were 2 symptomatic people attending a church event who later tested positive. Exactly the same thing happened in the Eastern Cape in South Africa, so we know this well. The church then, which had 92 attendees on the day, at least 35 of them became positive and 3 of these people died. From these contacts of the churches, another additional 26 cases were confirmed with 1 death. And this group was then considered to be super spreaders. The person here was considered to be super spreaders. And I don't want to go into that detail now, but the most recent explanations that are available is that these will contain, the aerosols contain small viral particles in poorly ventilated spaces. And when I say that, I want all of you to imagine in your mind a space which is very poorly ventilated, such as tea rooms and healthcare facilities or taxis. If an area is, and this combined with low humidity and high temperature will result in an infection of producing the right infectious dose. So ventilated rooms will actually halve the number of droplets after 30 seconds, which is half a minute. If it's poorly ventilated, the numbers of droplets will be halved in 4 minutes. And if it's non-ventilated, it might take anything up to 9 minutes or longer. So airborne transmission, in essence, is read as if the airborne transmission will increase if there is less than 3 liters per second per person, or if the carbon dioxide levels, if measured, is more than 1,000 parts per million. And this is what has now come out with the evidence. And it's interesting because for this to happen is very easy, but to get rid of it is also easy. And I'll try and go through those with you. So what is ventilation? Well, basically, we're looking at the comfort of fresh air, which means that you remove heat. And I believe at the moment there's a huge heat wave going on in the UK, which is badly controlled in homes. You can do this either mechanically or you can do it by solar gain because there's a big problem there. Temperature control, you can remove excess humidity. You can remove and dilute smell, toxic, inflammables and explosive gases. And you know, any one of us will know that if you walk into a room which is not well ventilated, you can smell it. But the most important thing from our point of view is we're looking to control and dilute airborne pathogens. Air from outside the building is called fresh air. Okay, and this is one of the simplest things we can do in low to middle income countries, particularly if you've got good weather. And what happens is that it comes into the room and it displaces the air that's in the room and removes a lot of the pollutants such as microbes, chemicals, and so on. But don't forget that if it's coming from outside, it's not necessarily free of pollutants. It could have spores in it, or it could have allergens in it, and all sorts of other issues that are happening outside. So even though you've got fresh air coming from outside, which might be microbial free, microbiologically free, it may not be chemically or odor-wise free. Coming back to the point about what is it that we're looking at. So in the absence of fresh air coming into a space, this space will contain carbon dioxide, particularly if all of us are breathing, and if there are plants, and there's odor, and there's particles, including viruses, which remain suspended in the air. And I'd like to draw your attention to this diagram on the right, the first one, where you've got 3 windows and a small door here. And this is very classic of looking at some of the RDP houses that have been built in South Africa. So basically, there is no way, because hot air rises, there's no way for this air to go out the door, but it therefore goes back on itself, as you can see here, to the window where it came in from. However, if the design allows you to have top ventilators like this, the air will go through and there's good cross ventilation and it can be removed easily. So if the room smells stale and it doesn't appear to be clean air, you know that you're in an environment which probably might be detrimental to health. So the principles of ventilation is that you avoid dark areas without natural movement. This is a classic example which happened at our hospital at Tygerberg, where they closed down certain areas of the hospital. Now, normally this passage would have been open and there would have been ventilation. Now, this whole area is dark and it's stale and there's absolutely no air movement in it at all. The other thing is that it's good if you're designing new premises that you have windows that can be opened, particularly in Africa. You can't normally do that in the European countries or in some of the colder countries because they have mechanical ventilation. And I'll come back to that just now. So we also want the airflows from the patient areas out wherever possible, preferably not towards the corridors because of the aerosols being able to transfer on airborne, on air, moving along from one area to the other. So we don't want it to be airborne. Natural ventilation circulation is probably the best, and many of our hospitals have that. If you have self-closing doors, you must make sure that there are baffle plates at the bottom. These are these little windows which have got little crisscrossy things so that the air is constantly moving out and through it. And of course, the air conditioning should be quiet and unobtrusive, particularly if you're using mechanical ventilation. And here again, it was so noisy or probably very cold that the patient stuck bits of paper into these to make sure that it wouldn't be blowing down on them. Very briefly from the WHO 2009 document on natural ventilation, there are 3 types of ventilation. First is the mechanical ventilation that many of us see in high-income countries. These are really very well controlled. I mean, you can have hot, cold, whatever you want in it, suitable for all climates and weather. expensive to install, very expensive to maintain, particularly if you're trying to get negative pressure ventilation in place. Now, this is a very important point for us because when we are designing healthcare facilities, particularly in respect to COVID, you might have people coming to advise you to say that you need mechanical ventilation. And we now know that for us, mechanical ventilation is important in certain very fixed areas, like operating theaters or areas where you want sterile environment or indeed where you want negative pressure. So looking at the natural ventilation, which is very suitable for mild and moderate climates, and in fact, much of the building that happens in South Africa and other parts of Africa go for natural ventilation. It's low cost, low maintenance. It has the capacity of very high ventilation rates, up to 28 air changes an hour. And you can control it by the occupants if you build it properly so the windows and doors can be closed at the right times. The disadvantage is that if you've got nasty weather like we have today in Cape Town, it's difficult to control that weather. The person that designs it must understand what's going on, and I can't go into the details now. It reduces the comfort level if it's very hot or very cold, and you can't provide negative pressure isolation with it as it stands. You can do things to it, but as it stands, you can't provide negative pressure ventilation. There are other parts which actually have mixed systems in place, which are both natural and mechanical. These, of course, are suitable. They are energy saving. They are flexible, but you have to have a very, very good architect and an excellent engineer who will help you with the ventilation, who's a good aerobiologist. These are expensive and they are difficult to design because not everybody can do it. So having said that, they are, of course, quite effective. So what are we looking for during the COVID-19 outbreak? We want as much fresh air as possible delivered into healthcare facilities and into homes. So generally, it is accepted now that we need 60 liters per second per person in general areas of the healthcare facility. And these can be provided in various ways, as I just mentioned. 160 liters per second per person, or patient in this case, in aerosol generating areas such as the intensive care unit, the wards themselves, and operating theaters. Now, in the general areas, we normally don't like to use fans in healthcare facilities. However, with this COVID issue, we have to think about whether we have freestanding fans or other fans because we're trying to make sure that there's a lot of air change. But you have to make sure that if you're going to be using a floor standing fan, it doesn't blow from one patient onto another and transfer the virus like that. We need expensive systems because we can't afford to. In general, if we've got windows that open, that works very well. And in the community, we're looking at 10 liters per person per second, per second per person, to be effective enough to remove the droplets and most of the aerosols. I'm going to play you a little video. This is a home video. I hope you can see it. A very nice house, which is not in fact mine, I just hasten to add. Thank you. Okay, so basically the reason I showed you that was to make 2 or 3 points. One is that when you are designing new facilities or you are renovating facilities in the healthcare sector, you must make sure that your windows and doors are balanced in a way that they allow natural ventilation. Sorry, previously, let me go back. Number 2, hot air rises. So if you're going to expect air to escape, you really want the ventilation going up, as you saw with that big room, and the ventilation going up towards the top. And certainly in our TB wards, and most of the TB wards that we see in Namibia and in Zambia and in some of the other countries, they have both the bottom window and they have a top window. So it is really quite useful to do that. Okay. The other thing which is quite inexpensive, which is known as a wind turbine. This is a very, you might have seen these in big warehouses and so on as you drive along. And this is a turbine that moves driven by air. And because it's driven by air or by the breeze, it draws up the air from inside the building and takes it up. Okay. And it does improve extraction. And therefore, this is another way where we are using a lot of these within Africa now, because they're simple, there's no mechanics attached to it, it's just a thing that spins and it draws up the air. And the MSF group are using it extensively in a lot of their facilities. Other systems that you have in place many times are the air conditioners. So these just bring in the air from within the room they are in, it's recirculated, and there's no filtering of particles. There's contamination because of dispersal of of skin scales and dust from the floor, and they should not be used for healthcare facilities. We certainly see them in healthcare facilities, but preferable not to have them there. The most common one that we find in healthcare facilities across Africa, and I've seen many of these in Nigeria, and in fact in South Africa, are the air conditioners. Now these are mounted on the wall, they're split level, and they draw air from outside. They only have a coarse particulate filter of about 60% filtration. And therefore you can't use them in sterile areas such as operating theaters, which I see very often. And also it allows temperature regulation. So it's good for offices and for individuals, but it's really not appropriate for clinical areas at all. These are the classic air handling units that one finds in all parts of the world. And I don't want to go into details of it, except to say that you push the cold water in, there's a heat exchange system that blows along. And as it comes past the fan, and from here it'll go into the duct system for the hospital or for the room, it cools as the fan blows on it because it's exchanging its heat from there. And this way, having exchanged its heat, the water carries on, the heat is removed and blown into the rooms. It goes back, and then again it goes through this loop here, and there's a heat exchanger here which allows it to warm up again. So the water is constantly recycled, and many of the systems in the UK in homes have this system whereby they've got a radiator and the heat of hot water, and it's all connected up, so it actually conserves a lot of heat. So the dilution of pathogens is really important, and this is known as air changes, or the rate of generation of pathogens are not known. So what you try and do is that the rate of dilution is that you try and get as many air changes as possible into a room so that you can dilute the amount of pathogen or chemicals or whatever else there is, and provide patient comfort as well. We're normally looking at between 6 to 10 air changes an hour, but now we are measuring them in a different way, which is known as liters per second per person. And in this case, we're looking at 60. It's very important to remember that if you're using ventilation, it is not a substitute, respiratory protection is not a substitute for ventilation. So it doesn't mean because you've got bad ventilation, you can walk in there wearing a respirator or a mask, because it's really not going to help a lot. The respirator or mask is used in addition to having good ventilation. However, the air doesn't need to be filtered if it's being blown out. And if it is filtered, like they do for bone marrow transplant units to bring in very, very clean air, then you have to look at Hepa filters, which have to be changed with great care. So do the pre-filters, because these could be very heavily concentrated with infectious particles, as we can imagine. You cannot recirculate, even if it's filtered. We do not want any recirculating of air, except for the Hepa filters in the operating theaters. And those are now they're going out of fashion rapidly. We really want air from outside. And the point of where the air is being blown out should not be near an intake or a window, because of course the soil air or the foul air will come right back in through the window again. That's called entrainment. So if you need clean air, which we don't for COVID, but anyway, if we do, the filters on the air supply must be after the fan, because it looks like this when you open up a filter. This is what it looks like. And then in that case, the ductwork where the air is being blown is under positive pressure, and the system will actually leak outwards. And I'll explain that to you in a minute. If the filter is before the fan, then you will get a lot of air coming in, okay? And they keep drawing itself into it. So you have to be very careful how and where you place your filter. So I'm going to show you, and everybody is confused about negative and positive pressure ventilation. So I'm going to take this opportunity to show you a short video, which I'm sure could explain it better than myself. So it maintains the high pressure inside the area, okay? Okay, well, the rest of it's all advertising, so I'm not really interested in that. But basically what you saw was that for negative pressure, if you're trying to keep the organisms inside the room, positive pressure if you're trying to blow them out. If you can remember that simple concept, you've done very well. I just want to explain this to you once more. And if this is confusing, I apologize, but it's very important that you understand this. So let's say we have a room with neutral pressure. And the air normally and there's a door here and there's a door there, there's a small anteroom, there's a window or two there, and the air just moves through normally and naturally. Nobody's blowing, nobody's sucking, nobody's doing anything. Now, if we force air in, like we do with mechanical ventilation, we push air into this room, okay? What happens is that this room now goes under positive pressure, obviously, because the air has come in, there's a lot of air inside, and this air in this room now has got to go somewhere. So it can't go back because the air pressure is coming from there. So therefore it moves out here into this room, okay? And it leaks into this room naturally. In other words, there's where the pressure is, otherwise it'll explode. So therefore it goes into that room and it naturally will leak out from the windows over here and so on. So the air direction will be from here towards the outside, which is the bathroom, let's say, for example, and it'll come into this room. So the question to you is, what is this area? If this room is under positive pressure, what sort of pressure is this room here? And the answer is this room would be under negative pressure compared to this room, which is under positive pressure, because it's leaking outwards, always going out. And this will be under negative pressure because thereafter it will actually move itself outwards, okay? If you look at it in a reverse, if the air is drawn in naturally and you are drawing air forcibly, okay, then what happens is that the air will move this way. This is what we do for negative pressure ventilation. This room is now under negative pressure because it is being drawn and sucked and so on and so forth. And this air direction goes this way. And of course, this room now will be under positive pressure because you're pushing air in. So this air, the air will always be leaking outward. So the point is that if you're looking at these two structures, what you normally find is that the air for negative pressure has to remain contained, and positive pressure has to be blown out. And if you can remember those two things, you've done exceptionally well. The other problem is that sometimes if you have two systems in one isolation unit or some other room, and the electricity goes, then what you don't want is for the room to suddenly go under positive pressure and start pushing air out, if it's a negative pressure room. You'd rather the room just became static with no air movement rather than go positive. The other thing is you can't have opening windows because you're controlling you're mechanically controlling what goes into it. Usually in an isolation facility, we like to have integrated bathrooms and toilets, particularly for COVID patients if we possibly can. And anteroom is useful for PPE and so on and medical devices and such, but we can't afford it in many hospitals in Africa. So it's not essential, but a designated area is just as good. And of course, don't forget negative pressure is expensive. The way we test it is by doing a smoke test, and this is just showing you that when you push here, you can see the air, the vapor or the smoke is going out that way. So it is actually escaping away from patients. The other thing that is used widely, and certainly for some reason for tuberculosis, there is now data that shows that it works in certain ways. So there's a specific UVC light, which is at 254 nanometer wavelength. And what happens is that this gadget here, which is this light on top, the air has got to move around it very slowly on several occasions, okay? And as it goes past it slowly, it actually gets in contact with the UVC and it kills mainly for tuberculous bacillus. And they're now suggesting for COVID, which I don't think is a very good idea because we don't need it. But basically what happens is it doesn't really pick up very large respiratory droplets. It doesn't disinfect surfaces or objects or whatever, so that's quite a waste of time. Unless you're in the direct line of vision, it has to be a direct line of vision, and it doesn't prevent the spread. So it is useful in its own given environment, but not necessarily for COVID. Okay. The other thing about UVC is that there are a lot of them wandering around, which are freestanding robots that look like the R2D2 sort of gadgets. In order to use those, they have to be very, very specific when you're going to be using them for disinfection of the environment and indeed the ventilation. You have to have your room has got to be empty. There can be no shadowing, and it must just be done with the direct line of vision. We use it in the laboratory where at night, before we go home, the whole lab is cleaned out. The safety cabinet is cleaned out, and you turn on your UV and it stays on for 8 to 12 hours. And you come the next morning and it's supposed to be decontaminated. If you're using it for air, it must be in a closed environment for air, and it recycles the air through it several times, and then it can go out. So this is being used in some parts of the world as a recycling unit, but the air moves through it very, very, very slowly, which is quite the opposite of what we want for COVID. And then the third place where they use UV quite regularly is for water purification. So once the person has done, this is for terminal cleaning and ventilation. And this comes back to the effort that if you find a single case of COVID in a particular institution, hospital, or in a workplace or whatever, the whole place gets closed down. That is absolutely unnecessary. It's a very sensitive virus, as you now know. It's an envelope virus that can be destroyed by simple chemicals, including detergent, and there's no need to keep closing down places because we know that the transmission occurs through the respiratory tract. So closing the environment is not going to help anybody. Same as wearing gloves, not going to help anybody. So once the patient with COVID-19 has been discharged, the infection control team will organize terminal cleaning. First thing you do is you turn on the ventilation, open the windows, do whatever you have to do, air out the room, as they used to say in the old days. You wear whatever appropriate PPE you have to wear, which is usually face cover and your hands, and you clean the room and you disinfect. You aim for about after 2 hours, the room is ready. You can go back in there. If you're using UVGI, which I don't suggest is a good idea because the maintenance is very high and it doesn't do what you want it to do, or if you're using fogging, using hydrogen peroxide or whatever else, there's no need for it. COVID is a highly sensitive, very fragile envelope virus, which will just die if you look at it too hard. Okay, so just be careful about that. And the new designs that are happening in various countries, this is in South Africa, they've redesigned the Worcester Hospital and they've just opened up the whole area. And this is just showing you how natural ventilation works. So you've got people sitting down here and you've got the offices above and they've got lots of openings all the way around. So when the air rises, it goes out through those windows and there's no need to have extravagant or very expensive mechanical system. This is the outpatient department where the mums are sitting there, absolutely in the open. And here is the secondary group that actually stays outside. They're the people that have got tuberculosis who are coming in either for tests or for verification or for medication. So you're looking at open spaces and you're using wide open systems to improve. So I just want to come back to one of my penultimate slides, which is looking at this. As you come from the community into an environment, you wear a cloth mask, which is the respiratory tract cover, and it reduces transmission into the environment. When you come into an environment such as the healthcare facilities, you can wear, for the large droplets, you can wear surgical masks. However, we now know that there are small particles or droplets that carry on, aerosols, which are produced during aerosol generating procedures. And in this case, you will consider wearing a respirator, preferably without, not preferably, but definitely without an expiratory valve, and one that fits very, very well. At the moment, we're having a huge crisis with our respirators because we're not allowed to import them from America or for Europe. So we're stuck with respirators that are inadequate for the, not fit for purpose at all. So I'd like to summarize by saying that if you want to spend money on sorting out your lives, particularly in view of COVID-19, you must spend it on things that you know with evidence that work, rather than what might work, such as fogging or UVs or whatever. If the following are in place, you have good, simple, effective policies, going back to the administrative controls to manage the patients. Engineering controls, which is ventilation, the spacing between beds, and finally PPE if you must. Look at the natural ventilation and good contamination of the respiratory equipment, and you can minimize the spread. So when I do a lot of our lectures here, I tell people that this is what you need to protect. You need to protect your eyes, your nose, your mouth, and your hands. You don't need to wear a lot of clothes. You don't need to put on a lot of stuff. All you need to do is to protect those. And once you can protect those, you are most likely to be the safest person there. I thank you for your attention.
Thank you very much, Professor Mehta. We will have questions at the end, so please put it in your chat box. I see some people, sorry, in the question and answer box. I see some people put them in the chat box. We will address that as soon as we've done with the next presentation. I want to introduce Dr. Portia from Zimbabwe, and she's going to present the country perspective from Zimbabwe. I will share her screen on her behalf, and then she can start.
Thank you very much, Anna, and good morning, colleagues. I'll present on our COVID-19 experiences, sharing with you some of the infection prevention and control perspectives. So that's the map of Africa and where Zimbabwe is. In terms of the country-specific information, we are bordered by Zambia and Botswana, South Africa to the south, and then Mozambique to the east. Our country population is a little above 13 million. We are actually due for a population census in 2022, but the 2012 population census gave our population at 13.2 million. We have had quite a lot of outward migration. The capital city is Harare. It's one of the 3 metropolitan provinces in the country, and there's 8 rural provinces. We have a total of 1,850 health facilities under the public health service delivery system. Of those, 6 are central hospitals, 8 are provincial or regional hospitals, and we have 57 district hospitals. So we have an estimated almost 1 million internally displaced Zimbabweans, but this is a bit outdated. There's been outward migration, as you know, with Zimbabweans all over the world, including within the SADC region and South Africa, and this becomes important because now the tide has been reversed by the COVID-19, and we have, in recent months, had massive inward migration of Zimbabweans coming back. due to the COVID-19 outbreak. So I need you to move to the next slide and then quickly to the next one, Anna. Thank you. Can I have the next slide? Hello, can I have the next slide, please? Thank you.
Okay, can you see that I've just displayed it? Is it the correct slide?
Okay. Okay, thank you. So in terms of the statistics on COVID, our first confirmed case in the country was on the 20th of March. And as of 10 August, the country has confirmed 4,748 COVID-19 cases with 104 deaths. We now have 1,524 recovered. The majority of the patients have been in the age group 21 to 40 years of age, with more males than females, with a ratio of 55 to 45%. We have also recorded quite a number of healthcare workers that have been infected, more than 400 healthcare workers, which constitutes about 11% of the COVID-19 disease burden in the country. As of 29 July, our analysis showed that of the 400 plus healthcare workers infected with SARS-CoV-2, 35% were nurses, 5.2% doctors, 16% student nurses, general hands and nurse aides about 5% each, and laboratorians 3%, environmental health personnel 2%. And we have recently realized more of the local transmission than imported cases, with Harare, Bulawayo, and Midlands being the most affected provinces. The majority of the cases have so far not required hospitalization. And the slide shows a spot map just showing where the COVID-19 cases have been reported in the country.
Sorry, but we can't do, I'm really sorry, but your slides are not moving at all. We've only seen your top slides, so we don't.
Anna, please move my slides. Thank you. So I need the one with the map of the spot map. Okay, so that was the country information. Next one.
Can you see now, Prof? Can you see them now?
Okay, so
yes,
now
we can see them now, yes. But I missed a lot of it, I'm afraid. Okay.
And Anna, can you put it on the slideshow, please?
I am on the slideshow, but it doesn't want to move, so.
Just go down and click on the icon.
It is on that.
Oh, okay.
Okay, so that graph just shows when our first case was reported up to where we are at now, where we have started to realize the exponential rise, and the country is now planning for surge.
Which one are you talking about?
Capacity. So I'm talking about
I'm still on IPC.
Just hold on one second.
Were you the one that started the genomic? Yeah, I don't know that you started, so I told the teams to start.
Please mute yourself.
Yeah, I'm still on my webinar, the IPC. Yeah, I can see. Yeah, it's already showing.
Okay. So I was just talking about the graph before the, yeah. So I was just saying we have now started seeing an exponential increase in the number of cases. And as I said earlier, the local transmission cases are now overtaking the imported cases. So now I will talk about the National Infection Prevention and Control Program before the COVID-19, and then finally I will talk about the IPC program as it has now changed to accommodate the COVID-19 outbreak. So this is a program that has been housed within our Directorate of Nursing Services. We have had the post specific for IPC focal persons introduced as far back as 1985, with IPC committees also present in some of the institutions. We had a boost through PEPFAR funding with the formation of the Zimbabwe Infection Prevention and Control Project, which was established between 2011 and 2017 to strengthen IPC programs across the health facilities in the country. The key partners being the Biomedical Research and Training Institution, as well as firming up of the Infection Control Association of Zimbabwe. So in 2016 to 2019, we also got a bit more funding in terms of the TB-specific IPC, again with funding from PEPFAR through our country CDC office. We have also now started working on the career path for IPC in the country in terms of introducing a postgraduate diploma in IPC at Bindura University with the support that has come in. So there's been the development of IPC guidelines in 2013, the National IPC Policy and Strategic Plan, and an M&E framework in 2015. The National IPC Committee and technical working groups were formed looking at infrastructure, training, surveillance, monitoring, and evaluation by 2016. And there's been within the Ministry of Health and Childcare in-service training program with an IPC coordinator and core ministry certified team of IPC trainers are being put in each province. And this has also seen the strengthening of the IPC curriculum in the pre-service training programs for some of the healthcare cadres. There's been strengthening of the Infection Control Association of Zimbabwe and strong linkages with the Infection Control Africa Network. And this has really assisted us as we rose to embrace the COVID-19 challenge in the country. Within the HATI program, there's been the development of a draft national healthcare worker TB policy and screening program for healthcare workers for TB. And I think we need to ride on that to do the same for COVID-19 in view of what I mentioned, a number of healthcare workers coming down with COVID-19 infection. There's also been assessment of the quality of the IPC programs within health facilities in the country using a modified WHO IPC assessment framework. And there's been a few facilities that were selected for inclusion in the first round using the WHO's 8 core components. I already mentioned that the country runs about 1,850 health facilities. So this is just a handful of facilities that were assessed. I'll just talk about some of the results of that assessment using the WHO tool in the next slide, please. So in terms of the individual reports, this is just an example, but of an actual scoring, which showed a SWOT analysis vis-a-vis IPC. The highest was a score of 94.1, which facility showed strong executive management support for IPC, with an IPC department, with a full-time IPC nurse dedicated to the program, a multidisciplinary IPC team, which includes doctors, a microbiology lab support within the institutions, with a identifiable current IPC plan and budget, and a link nurse is available to monitor the IPC practice within the clinical area. So that was one of a best practice, which then in terms of the average score was at the upper end of intermediate category doing very well, and needing very little to move into the advanced category. So in terms of the low scoring health facility, in terms of the strength, there was presence of enthusiastic. This will be the next slide, Anna, thank you. Presence of an enthusiastic ophthalmic trained nurse who is running the IPC program with knowledge gained from ophthalmic nurse training. IPC program in place though weak. So, and the comment there in terms of the average scoring was there is need to establish an effective IPC program in all areas at this facility, with the IPC implementation needing scaling up. So there's been those tangible scoring and indications and pointers to where there is need for improvement. But remember, this is before the COVID-19. And with the advent of the SARS-CoV-2, there is need to really escalate that and ensure that the facilities are high scoring. But this is the task that we have to now embrace. Can I have the next slide and then the next one, Anna? Thank you. So in terms of the Zimbabwe National COVID-19 Preparedness and Response Plan, which was launched in March, just before, a few days before we were to confirm our first case, there were 8 pillars. The 9th one was the law enforcement and security that was added after the launch of the plan. But I will then zero in on the infection prevention and control as pillar number 6 of our COVID-19 preparedness and response plan for Zimbabwe. Next slide. Okay, so in terms of some of the IPC challenges, the IPC programs introduced into government health facilities have been struggling with staff shortages. And this is across the board, and this has been part of our challenges within the general health service provision within the country. So we did have the IPC focal persons that I talked about, but oftentimes they had to multitask and then sometimes be removed from the work of infection prevention and control. At the primary health care level, there are weak programs, and the IPC is one of sometimes the non-existent ones. Lack of dedicated budget for IPC programming, and shortages of personal protective equipment and consumables for implementation of the IPC program. High turnover of staff, as I said, you then have somebody trained for IPC, and then they are quickly shipped to the next needing area, and oftentimes they won't then be able to practice the IPC. In terms of outbreak response and management, we have had weak IPC component until COVID-19, where we have realized that we really need to firm up on IPC. The national IPC guidelines updated in 2019 had not been disseminated. There are specific training requirements for COVID-19, which also require the translating of the training into practice. So what have been the solutions to these challenges, particularly as we address COVID-19 in Zimbabwe? So I mentioned the establishment of pillar number 6 as part of the national COVID-19 response plan and strategy. And this has been based, their work has been based on the national IPC committee, which, as I mentioned, was established way back in 2017. In terms of the pillar number 6, the lead is the Director of Nursing Services, with the co-chair being Professor Valerie Robertson, which, as you know, is part of the ICANN Secretariat. We have had support from the UN agencies, UNICEF, WHO, as well as the Infection Control Association of Zimbabwe. And we also want to appreciate and add into that bracket of support the Africa CDC in terms of availing resources for training and capacitation of IPC in the country. We have a Ministry of Health and Child Care departments and directorates as part of that pillar, as well as other ministries and agencies, including the ministry responsible for our public construction, environment, and water. And we also have the partners and stakeholders from across the divide. Next slide. So in terms of infection prevention and control during the COVID-19 outbreak preparedness and response, the aim, the general objective was to limit transmission of COVID-19 in communities and in health facilities by adherence to IPC guidelines and protocols, and ensure rapid implementation of IPC activities. So among the activities identified was the development of an operational plan and budget. As I said, sometimes IPC has not been properly funded, so there was need to ensure that there is a costed plan. Establishment of the IPC reference materials for use at national and subnational levels, IPC capacity building at all levels of the health system, and then PPE supply, including local production, and establishing the quality systems for the PPEs, whether imported or local, hospital infrastructure in relation to IPC, and then the IPC program assessment, monitoring, and evaluation. So there's a selection of some of the IPC reference materials that have been developed by the IPC pillar, including a guide for the use of PPEs for COVID-19, the IPC in the community and at household level guideline, as well as standard operating procedures in health facilities. And that has really assisted colleagues to implement even as we fight the outbreak. So there's also been training modules developed for IPC and COVID-19 based on the WHO, CDC, and ICANN guidelines, aiming for IPC capacity building at all levels of our health delivery system, looking at advocacy presentations for health professionals, health managers, lab staff, updating national IPC trainers on COVID-19, 3-day specific training on IPC and COVID-19 for healthcare professionals, and a 1-day training for support staff, training aimed at the ports of entry pillar for quarantine center staff, and a 2-day integrated training for IPC and case management. I should also say, in terms of COVID-19, we have also agreed that each time there's case management training, there has to be IPC input into that training. And recently we've been getting support to train community volunteers. We've also factored in IPC into that training. So there is, again, a number of SOPs and guidelines that have been developed as shown. So in terms of the implementation for IPC capacity building, there's been short workshops organized by the College of Public Health Physicians and ICAS, and that has helped to update even professionals within the private health service delivery sector on IPC in relation to COVID-19. Updating national IPC trainers using the Zoom platform, and there were sessions conducted in April, but also presentations and SOPs have been circulated to all the national IPC trainers. So phase 1 was completed, and phase 2 includes the rollout of the integrated IPC and case management training to fill the identified phase 1 gaps, and also IPC input into training by other pillars. As I mentioned, community training, IPC is really important, as are other aspects and other pillar inputs, but also for the quarantine centers. There's ongoing training of trainers of COVID-19 with support from Africa CDC and the World Health Organization. And we want this to extend to mentorship and walking colleagues through and ensuring that within their work areas, particularly within the isolation facilities for COVID-19 patients, IPC really becomes second nature to prevent health acquired infections. So in terms of PPE supply management and local production, there's been the development of a PPE policy based on the WHO guideline for PPE and recommendation for that PPE guideline to be used, and also indicating which PPEs for what persons, for what risk levels, and so on. There's been quite a lot of confusion in terms of deployment of PPEs for the various levels of exposure. The IPC pillar has also examined donations and locally produced PPEs for quality, giving advice as to the suitability. There's also been the setting up of a subcommittee to develop specifications, including or involving the Standards Association of Zimbabwe. And the procurement of the PPEs is also assisted by IPC, even though it's under the procurement pillar. Next slide. So in terms of the program assessment, monitoring and evaluation, there's been the establishment of a database to collect data on the numbers of healthcare workers trained. This is in the process of being reviewed and updated as the trainings continue and as the gaps we hope eventually narrow in terms of the capacity for IPC. A risk assessment tool has also been developed to evaluate the implementation of the IPC program at the department and facility level. There's also been the facility site support visits, which should continue and even intensify as the outbreak is evolving in our country. And there's been a site support visit tool that was finalized for use at the treatment and at isolation facilities to evaluate progress on the COVID-19 systems establishment. The supportive supervision tool includes both the IPC and case management indicators, and also a reporting system on the IPC indicators. Next slide. So what have been the lessons learned for Zimbabwe? One is that an overburdened health system can be overburdened with training. Much as our system is leaked out a lot of the skill and experience, we also need to strike a balance between the implementation and training and capacity building. So there's been the development of integrated training of the case management and IPC modules, as I said, but a lot of integration in terms of our approach to training and capacity building, to be followed by empowering the provincial and district teams to run their own training through strengthening the training and mentoring skills and implementing supportive supervision. Introducing the tools for supportive supervision and self-assessment, as well as observational tools and a reporting system to monitor progress while implementation is happening. We also realize that training workshops on their own are not sufficient to achieve good IPC practice. This has been exemplified by the fact that we have realized more than 400 healthcare workers infected, including student nurses. Among some of the reasons was inadequate PPEs, but also the behaviors within the health facility and lack of training. So I think there is work to be done in that space. In terms of new guidelines, there's been guidance on the risk assessment for mandatory quarantine of frontline workers exposed to confirmed COVID-19 cases to allow a more accurate analysis of exposures and identification of effective interventions. Finally, multiple partners supporting training across different pillars without coordination can result in mixed messages and confusion of practices. So good coordination and collaboration is called for, and it's yet to be achieved. I think that will be my last but one slide. The identified gaps have already been mentioned. I wish to thank you for this platform and for allowing Zimbabwe to share our experiences. You have a list of people that the Minister of Health and Childcare wishes to acknowledge. Thank you very much.
Thank you very much, Dr. Portia. I'm going to hand over to Dr. Wande, and she's going to handle the questions and answers. Thank you.
Thank you very much, and thank you to our speakers for today, Prof. Shine and Dr. Portia. It's been a fantastic session. Just to let the participants know who I have on my panel today. Today we have our colleagues from WHO headquarters, from US CDC, from ICANN, from Public Health England, and Resolve to Save Lives, along with my colleagues from Africa CDC. So we encourage you to put your questions in the Q&A. I know that some people have put some questions on the chat box too. So I think most of the questions have really been directed at Prof. Shine, and thank you very much for a fantastic presentation. I know that you've answered some of them in the Q&A, but I realize some of our colleagues online cannot see the answers to those questions. So I will read out some, and please feel free to just unpack it further. So the first question is looking around, most high-rise buildings and apartments have long corridors. Is it safe to walk in these corridors in the event that one cannot walk outside? And what is the number of people in closed corridors at the minimum? And I think this is also something looking around workspaces that have these long corridors, and as countries are starting to open up, we will be doing a lot of walking around on these corridors. So I think it will be helpful for our participants to learn from this, and maybe it can inform some of their national policies. Over to you, Prof.
Thank you. Okay, so a long corridor is like a funnel or like a tunnel. If there is air coming into the corridor, it'll actually go along it and it'll come out the other side if there is an exit point. If there's nothing happening, if there's no air coming in and there's no air going out, then it's a dead space. And if it's a dead space, then of course, you're not going to clear any microorganisms or pollutants or anything. Walking up and down the corridor is absolutely fine. I don't think there's any reason not to do that. But I think the point I want to make is that when you go back and have a look at your corridors again, make sure that there is a window at either end that can either be opened or partially opened, so that there is movement of air along it. And that's from that point of view. But the number of people occupying space is really interesting. We've just had a very nice discussion, and I think the WHO will be coming out with some recommendations. But there was a great variation between 1 meter and 2 meters, and a lot of confusion about how far people should be from each other. So when we found that our healthcare workers got infected in the tea rooms because there was no ventilation, they dropped their guard, they were sort of flying around, they'd been so exhausted. They just sort of showed each other, you know, pictures on their phones and so on. They were really close together. So now what's happening in our tea rooms, and this was something which was done by Dr. Boyle, which I think is a brilliant idea, is you put a tape mask around the space of 1.5 meters in the tea room. So what we've done is we've staggered people going in. We've increased the spacing, and it's absolutely vital that that distancing is maintained, even though you're wearing a face cover and you're doing your hands. And you maintain that all the time. Okay, and I think that is a very important point. So walking in and out of the corridors is fine. You can walk past somebody because, as you well know, contact means that you have to be within 1 meter of a person for 15 minutes or longer without appropriate face cover. So walking past somebody in a corridor doesn't matter at all. Okay, so I wouldn't worry about that part of it. I hope that answers your question.
Thank you so much, Dr. Portia. I think this question is really, participants want to know, looking at healthcare workers' infections, are you able to trace where, I think that's a lot of questions that has come to many of us, is that for your setting in Zimbabwe, are you able to trace where these health workers got infected? Looking at, was it the facility level or was it at the community level? And if yes, that you're able to disaggregate that data, what tools were you using? Our colleague from Malawi is open to learn from us. Over to you, Dr. Pasha.
Okay, so thank you for the question. And it's also been worrying us, and there's investigations underway, particularly within the city of Bulawayo, where there is a lot of local transmissions compared to the imported cases. And we didn't want to incriminate the healthcare workers for being part of the conduit into the local transmission. So we in terms of the specific question asked about the tools used to investigate, our system, surveillance system is firmly premised on the integrated disease surveillance and response, WHO Afro guidelines. But with COVID-19, we also received training through Africa CDC on the WHO on event-based surveillance. So we are combining those two. But to answer the healthcare worker question is a bit difficult for us, because we have had industrial action where, and then as part of trying to resolve that, the ministry introduced what they called flexible working hours. So that has seen nurses, for example, reporting for duty just 1 day a week and 1 night duty a week. So we have also anecdotal evidence that some of the health workers are now working more elsewhere and then just coming for the few days to the public health delivery system. So having said that, this is why we really want to get to the crux of the matter and find out whether our system is faulty or there is something that we can correct in terms of both the private sector health service delivery and the public sector health service delivery. But I would say this is still works in progress, and I think we'll be happy to share at a later time our findings.
Thank you very much, Dr. Pasha. Fantastic response to that. I think that's something that we are all worried about. My next question is to my colleague from WHO headquarters, Alice. The question really goes like, do you have to wear a mask when walking on less busy streets? So I think, again, just looking around, addressing issues around when countries start on lock, what are we saying to participants in terms of the use of face mask or face coverings? Over to you, Alice.
Thank you. I hope you can hear me well. So I think Shaheen also spoke a little bit to that point. We are recommending fabric masks or the face coverings in area where there is lots of COVID transmission and where physical distancing cannot be maintained. So if you're walking outside on a road and you're not coming into enclosed spaces with other people where you can't be at least 1 meter away from them, you don't have to wear a mask outside. If you then go into a shopping store or a building or things like that, then we would recommend that you take out your mask and you put it on. But if you're just walking around the streets outside or anywhere that is outside, usually we wouldn't recommend masks unless you're in a big group of people or a large gathering, as we've seen sometimes with religious settings or protests or things like that that are also happening outdoors, but there are lots of people. So really just keep those things in mind. If you can stay away from people and you're outdoors, there's no need for the mask. Unless, of course, the local authorities are saying that it's mandatory, then you should always follow those local guidance first. I hope that answers the question.
Thank you. That is really useful. So colleagues, I see that most people are putting their questions on the chat box. It's going to be difficult to answer your questions unless you put it in the Q&A box. So I think I will throw this question to, this is a follow-up question saying that as a follow-up to this question, the Interfaith Council in Kenya has released guidelines for church attendance, and they've given some guidance around young kids shouldn't be there below 6 and above 65, which is normal, and a maximum of 100 people. the question is maybe what I would ask Prof Prof Shine to reflect on is, are there any guidance? I think what the person wants to understand is that, is there publications that support this age group, that is 15 to 58 years old? Because the cases in Kenya is rising. So I think just a bit of guidance on when we say that we're unlocking and we look at specific age groups, what are we thinking when we make these recommendations? Over to you, Prof. Shine.
Thank you. Actually, it's an interesting one because we're just about to reopen schools, and there's quite a bit of uncertainty about the children and who's going to school and who's not going to school, and parents not allowing their kids to go to school and teachers not wanting to come to school, and it's quite a performance. Again, there has been wonderful discussions on this matter globally, but also at the WHO. And the evidence suggests that children under the age of 7 are asymptomatic, but they could be carrying virus, and they could be transmitting virus. So even though we are suggesting that initially we said that they should not be wearing face covers, I'm now concerned about our healthcare facilities and our children in South Africa. So particularly we are saying they should wear covers. After the age of 12, the carriage of and the number of virus shed is very similar between the 12-year-old and the 60-year-old, if you like. So they go into the adult mode, in which case they will wear face covers and they will wear masks, fabric cloth masks. In South Africa, it is compulsory to wear a face mask when you go out of the house. So if I'm going out to walk my dog and I'm walking all by myself in the forest, well, I'm not going to wear one. But if I'm going anywhere else where there's more than, let's say, 10 or 15 people, like a shopping center or taxi or whatever, we will be expecting them to wear face masks. I don't know if that actually answers your question, but we have said that everybody over the age of, well, everybody should wear a mask, but if you are from 12 upwards, you will wear a mask. And if you are under 5, you can try and get away with it. And the bit in the middle, we still haven't decided. But if you go to school, we suggest that you do wear a face cover, you wear a mask. I don't know if that helps.
Thank you, fantastic. So very quickly, I would throw this question to my colleague, Emilio from Public Health England. So this question is quite interesting. It says that when you're using air conditioning in the car, will it be safe to wear your face mask or face coverings, or should you just turn on the air conditioning and open up the windows for proper ventilation? Over to you, Emilio.
Thank you, Wande, and thank you for the question. This also goes back to a couple of the comments that have been made previously. The same principles apply in a car. It's an enclosed space, and it's unless you have a limousine, then it's very difficult to maintain social distancing. So we would recommend that the occupants wear a mask, unless, of course, they are from the same household, or if local regulations allow households to travel together in a car without masks, that's fine. But whether you open the windows or put the air conditioning on doesn't negate the need to wear a mask. So you may need the air conditioning for comfort, and so if you have it, then that's fine, but it really shouldn't take away the need to wear a mask if you're sharing a car with another person outside your household. I hope that answers the question. Over.
Okay, thank you. So very quickly, Elizabeth, if you would like to take a dive at this question based on some of the things that you're seeing in your country and perspective. So this is really, there's been a lot of fuss and news around the use of face masks and the effect on people with breathing problems like COPDs and asthma. So the question is, again, to all of us, is there a protocol for use of face mask in this group of people? Elizabeth, over to you.
Sure, thank you, Wande. I'll be happy to answer, or at least start to answer that question. I also wanted to, if I may, follow up on another question that was about Kenya and the church services and the limitation of church services to 100 people. And I think we need to think personally, I think we need to think more holistically about absolute numbers of people, because just 10 people in a very small room with poor ventilation could spread the virus just as effectively, those 10 people, than if you have 100 people well spread out, at least a meter apart across, a large field. So one thing I would suggest is that people, when they're making recommendations, think not only about the absolute numbers of people that can be together, but also what is the space that they're going to be in, and make sure it's space appropriate for the number of people for any event or gathering. That being said, when it comes down to asthma, COPD, we have had a lot of pushback by people in America who have been saying that because of pre-existing breathing conditions, that they should not have to wear a mask. And that has, there's been then the flip side pushback from the public health authorities, which is the very people who have previous lung conditions are the kinds of people who should be wearing a mask for their own protection, because there's more and more evidence that not only does the mask help stop you from transmitting the virus should you have it, but also provides levels of protection in case you are exposed to the virus. So the general recommendations then are for people who really cannot tolerate masks is that if they cannot tolerate masks and have such a poor level of lung function, then they should be avoiding situations in which they even need to wear masks. In other words, avoid situations where they're going into the shops where they might be exposed to people, for more than 15 minutes at less than a meter or a meter and a half apart. And that they may have to do a little bit more self-isolation during this time, largely to protect themselves as well as to protect others. Over.
Thank you very much for that. So I think this last question, Anna, before I hand over to you, really I would throw it to Karen from Resolve to Save Lives and Prof. I think I saw an interesting comment just earlier when you were making your presentation. And for my own knowledge is around the dead space between the ceiling and the roof. I think that was a bit new to me looking at the ventilation bit of it. So Karen and Prof, if you would like to just unpack that a bit for us as part of the discussions today. Over to you, Karen, then right after Prof. Shine.
Very quickly, yes, no, she's absolutely right. Karen, of course, as you know, is an expert in TB IPC, is well recognized globally on that matter. So most of the time that when you see one of these turbines, these whirlybirds as they're known, they're usually sitting in warehouses where there's absolutely no ceiling. However, if there's a ceiling in between the roof and the space, there's a space over here, they are completely ineffectual. Okay, but Karen is going to elaborate on that because she knows a lot more about it, I'm sure.
Yes, Karen? I think, hi, thank you so much, Wanda, for the question. I think that what I've seen on multiple site visits all over the area are that people love dropped ceilings. And when you drop a ceiling, then you have created exactly what Shaheen just described, a dead space between the ceiling and the roof. So you can have 25 whirlybirds, but they're going to be ventilating the dead space, and it's not going to get into the clinical area. So in general, we advise people not to install dropped ceilings. If you insist, then you must have holes in those ceilings so that the whirlybird, which is quite cheap and quite effective for improving ventilation, can work appropriately.
Thank you very much. That was a new thing to learn, and I think this has been very useful, and I hope our participants find this useful. As you can see, it's been an exciting, engaging conversation, and we're definitely going to be doing this next week. So tell your colleagues, bring your colleagues along, and I will hand over to Anna to take us through the closing session. Over to you, Anna. Thank you.
Thank you, Wande. Thank you, everybody. We're already a bit over our time. I see, just want to thank everybody that attend. I want to thank our speakers and all the panelists as well. For the ones that are asking about the QR codes, it is put in the Telegram box. You have to download the app before you can scan, and it's only valid for the sessions. So you need to just go to your social app and download it to get your certification. We don't do any other certifications. I will just share the screen again with a closed or the end code so that you guys can just use that to scan. If you scan the codes, it will automatically tell you that you've ended the session and that you've got your attestation, and immediately from there. Okay, so I'm just going to quickly share my screen. And there's the end code. So if you scan the end code, you will be able, after you scan the beginning, you'll be able to get your attestation. And then from there, I know there's a lot of questions still in the question and answer box. We will try and go through that and see if we can answer them. Please post them on the Telegram community of practice as well, and we'll see how far we can actually help you with that. Thank you. Thank you very much to the panelists as well. Some of us will be still available on the Telegram to see how far we can help you. If you do have any burning questions, you can contact ICANN or Africa CDC, and we can see how we can address your questions. Okay. Thank you very much, everybody, and we'll hope to see you next time.
Thank you. Goodbye.
Thank you. Thanks a lot, everybody. Lovely to be here again. Thank you. Bye.
All right, bye. Thank you, everyone.
Thank you, everyone.